Well, good morning or good evening, depending on when you're watching this recording, which is made for the District Anesthesia Education platform of a talk given on the 8th of October 2024. My name is Ben Gaunt. I'm the Clinical Medico-Legal Advisor for the Eastern Cape Department of Health. And this talk is really to take us through consent, or at least some of the aspects of consent that I think are useful to be aware of. We'll try and make it a little bit specific to anesthetics, but it really applies to most of what we do as clinicians and doctors. And as the subtitle says, it's not always quite as simple as yes or no. So the idea is to just highlight some factors that could be useful to you in your practice. I'm going to talk about what consent actually is, some important components of consent to just help you kind of navigate what it is you're meant to be saying and doing, and quick note on documentation and dealing with a few other things. So that's where we're going. I thought it's helpful to start with this rather arresting thought that consent is fundamentally an agreement to suspend the normal laws of our society when it comes to what we do to other people's bodies. In general life, it is not acceptable to walk around and stab someone with a needle or cut them open. We call that assault or attempted murder or who knows what else, but the reality is that what we get to do in our everyday practice actually is a very special case. It's people coming to us and allowing us to do things to them that would be completely unacceptable in any other setting. So when we approach consent with that mindset, it highlights, I think, why consent is so important. We need permission to do the things that we're going to do, and obviously that permission can only be properly given if it is explained, if what we're going to do is explained properly and in ways patients can understand, and there are a few other things to be aware of. So that's the mindset going into it. It's everyday stuff for clinicians, but it's significant life events for the people who are giving the consent, our patients. So there are three kind of important words, aspects to this consent process. The first is the patient's capacity. The second is the information that we provide. And the third is this concept of voluntariness, which we will look at in a little bit more detail. So capacity has two components. The first is the age of the patient, and the second is their decision-making ability, and those are obviously not one and the same thing. So age, we often focus on this aspect quite a lot in our practice. Is the patient older than 18, and if not, we need someone else to sign. But it's more than that, or it's more complicated than that, because actually there are several different ages, primarily three, 12, 16, and 18, which our law has designated as important in terms of the capacity to give consent from an age point of view. This table on the right, which is very small on the slide, comes from the Medical Protection Society. It's available in the Rural Doctor's Handbook, and you could probably find it online, but it sets out a little bit more detail than the list on the left. But just, very briefly, there's no age limit, for example, for a termination of pregnancy or an HIV test, no age limit imposed in terms of the person's capacity to give consent. They do still need to have the ability to make the decision, which we're going to come to next. Over the age of 12, they can consent to medical treatment, contraception, surgery, and as a child parent. That's quite a significant list. We'll touch on the surgery a little bit more, but that is actually quite interesting, that children of 12 consent with their parent or guardian's assent. So they should be assisted, and there's actually a special form that they're meant to do. but the surgery itself can be consented to by the child as long as they're over the age of 12. I think that's certainly a new one for me. And in our theatre contexts, I wonder how often we actually get the child's consent, or even bother sometimes to explain to the child exactly what's going to happen. So I think that's something we can probably do better and be more aware of. 16 is an important age for giving consent in terms of sexual intercourse. That's obviously applicable in teenage pregnancy, and also obviously in terms of what constitutes rape or statutory rape. I'm not going to go into that in any detail, but for male circumcision, they need to be 16 years or older to consent to that. And just to point out that virginity testing, although that's not widespread in our country, it is completely illegal to carry it out under the age of 16, and over the age of 16 obviously needs the consent of the woman. I had an interesting case the other day where I was asked about a case where a mother, an angry mother, brought her 15-year-old to the clinic and wanted virginity testing, and it's quite easy answer. It is illegal to do it. So knowing what these age cutoffs is important. And then 18 years and older for sterilization procedures, unless there are special circumstances, and that's all laid out in actually special acts that deal with it. So the second aspect of this is decision-making capacity. And in our law, we presume that once you're over the age of 18, you have it, unless otherwise specified. Under the age of 18, and particularly those children around the age of 12, where they've just kind of graduated into this ability to give consent to a variety of things, they do need to be able to understand what information is being shared with them. They need to be able to appreciate the consequences of their decision and the reason why any treatment being carried out or not being carried out is advised. So it's important that if a younger person under the age of 18 is going to give consent, that you need to be happy that they understand what is going on. And interestingly enough, even for the children under 12, a 10-year-old can consent to an HIV test if they meet these criteria, that they understand and appreciate the consequences of their decision. Note that it is decision specific. So especially under 18-year-olds, may have the ability to consent to an HIV test, but a more complicated or more consequential consent, for example, for complicated surgery, might be beyond their capacity to fully appreciate. And so it's not one size fits all. And of course, people's health and ability to understand these things does change over time. There's some special circumstances to be aware of, and this applies to adults as much as to children, in fact, perhaps more to adults. People who have cognitive impairment will obviously potentially have a limited ability to understand the consequences of their decision or the information. Relative risk is a complex concept in itself. The second area is communication difficulty. That might that's more about the mechanism of communication. People with a hearing impairment or speech impediment who are unable to or struggle to fully understand the communication. And then, of course, language itself, both the what language this conversation is happening in and whether the healthcare worker and patient share a language or a first language. But also the complexity of the language that one speaks. I think as healthcare workers, we very often forget that many of the words we use in daily discourse are not normally part of the English language at any rate, and I'm sure that applies in every other language. We use a whole bunch of fancy words that your patient might not necessarily understand. So making sure that things are explained in as simple language as possible without obviously patronizing the patient. And then lastly, the special circumstance of the so-called wrong decision. We might take consent or attempt to take consent from a patient who has a different worldview from us. We're going to get onto this as well in a bit, but they might decide differently to us, or what we would in their circumstances, or we think we would. And just because they make a decision that's different to what we think the right decision is, doesn't mean that that is not valid consent. There's no law against making this or that decision, a wrong decision, a bad decision. Respecting our patient's autonomy is super important. This is just an example that I thought I'd throw in there, and kind of food for thought, both for anaesthetists and surgeons. A real life example from back in the day at Zitulele, where we had a woman who was profoundly deaf. She couldn't hear at all. She had some sign language, but none of the medical staff had sign language. And the doctor in the picture reached out to our speech therapist and audiologist, who set up this kind of multi-way communication. It's a Skype call, clearly back in the day, with two sign language interpreters from Cape Town, because one kind of was more fluent in the type of sign language the patient had, and the other was more fluent in the type of sign language the audiologist had. So we were kind of having this multi-part conversation to explain to the lady, whose pictures used with consent, but didn't know she would be in this presentation, so I have obscured her face. But we were explaining to her what her pregnancy and labor was going to be like. This was her first pregnancy, and also what might happen if something went wrong, why we might need to do a cesarean section, and what that would entail. And so, in fact, although we were hoping she would deliver vaginally, consent was taken for a cesarean section. And it turned out that, on Saturday night she needed a Caesar without the audiologist or anyone else around, but it had all been clearly explained to her, and so she knew what was happening to her, and she had been part of that decision-making process. And I just thought that was such a wonderful example of overcoming those communication difficulties. One does have to be proactive sometimes in thinking ahead. When the patient themselves is unable to give consent for whatever reason, either they're underage or they are unconscious, there's actually a hierarchy of surrogates for giving consent, and it's just important to be aware of these. So I've put these out on the slide here. Obviously, if the patient has given an advance directive or appointed a proxy to make decisions on their behalf, those are right at the top. A person who's authorized by law or court order, that often takes time, but may be applicable, especially in patients with known intellectual impairment or end-of-life care issues. The patient's spouse or partner is next, then a parent, then a grandparent, an adult child, a brother or sister, and lastly the healthcare worker. So we're right at the bottom, and we have to fulfill three criteria. In fact, ideally, the other surrogates should also, as far as possible. We must make decisions that are in the best interests of our patient, and that is also slightly vague, but means we are not acting in anyone else's best interests but the patient. That it's not for something that they've previously refused. So if this was something that was discussed with them while they were able to understand and give consent, and they withheld consent, going against that previously expressed wish is not acceptable. And also, it's important that if a healthcare worker is going to give consent, it's for something that can't be further delayed. So it's an emergency setting. Those are important to remember, and then a healthcare worker can step in. Obviously, our Caesars are often like that. Again, the 14-year-old is able to consent to surgery, theoretically with the correct form, and they should be assisted by their parent or guardian. So if the parent or guardian is not there and nobody else from that list of surrogates, the healthcare worker steps in to assist the patient and signs in that capacity, but the patient herself should actually be signing too. There's more complexity with children. Sometimes there's an issue of which parent. So mothers are automatically the natural guardians of their children. But fathers, their parental rights are subject to all sorts of sub-clauses, including whether they are married to the partner or not, whether they at the time of conception and at the time of birth. There's different subclauses, whether they have acknowledged paternity of the child, whether there's an adoption order. All of those things impact which parent has consent rights, and obviously if there's a disagreement, which parent maybe has the final say. That can be complex, and as always in healthcare or medicine, if you don't know, ask. Caregivers is another issue. So the law does allow caregivers to give consent for certain things. HIV testing is one of them, but the caregiver is the person who is assumed to have parental rights because that is how they function in life. Now, it's a bit of a gray area again, but if the caregiver is not granny who brought the child to the appointment because mom was at work today, that needs parental consent ideally, unless it cannot be delayed, of course. But the granny who's looked after the child since birth and the mom's whereabouts unknown, even if granny doesn't have legal guardianship assigned to her, she would have rights to give consent. So, trying to understand the circumstances that your patient or child particularly is from, and what the legal implications are is important, so that one acts as responsibly as possible. Emergencies we've spoken about. Often getting consent is difficult in those circumstances, and we've spoken about when the healthcare worker can step in. When the healthcare worker and parents disagree, you're onto contentious ground, and there quite often a court order is needed. There are times when in life-threatening moments the healthcare worker can act in the best interests of the child, but again, you usually need to get advice from somebody senior, because the law ultimately prefers even the Minister of Health to be making that decision. And I've spoken about children needing to use Form 34. That is a special form which basically takes you through the steps of consent, making sure things have been explained and that the child understands, and documenting who the parent is, who's assisting, and who the witnesses are. It's just that that's actually what's required in the Act. Information. We take this part for granted as well, but information is really important. And what information is described in the law in a very interesting way. So you need to give them full and accurate information about what's wrong with them, what diagnostic procedures may need to be done or have been done, what proposed treatment is advised, and the cost of the treatment, the cost being especially important in the private sector, obviously, but even in the state sector, I think it's appropriate to have cognizance to the fact that some treatment plans require a lot of back and forth from referral hospitals, a lot of time spent even at the clinic or the hospital. And so even people who are not necessarily financially paying at the counter for their services, their time and travel might be significant financial burdens or just opportunity cost, and it's important to consider that. An example is a patient with advanced cancer, perhaps, who's going back and forth to oncology 400 kilometers away, but with little hope of really improving, especially given their socioeconomic circumstances and the other factors of their illness. And at what point does one make sure they understand that there are other options? I think that the answer to that question is up front. But how much information is full and accurate? How much do you actually need to tell them? Well, again, context matters. So this is not just about how much information, but how it's transmitted. You need to take into account the patient's culture and beliefs, their educational level, their personality, their occupation, again, the language that you use, and important not to make assumptions about something. So the law does put this responsibility in your hands as the healthcare worker. It says that you need to decide what full and accurate information is. It says that you need to give them knowledge or information about things that you think they will attach importance to, which makes it quite difficult to just arrive and take consent in the passage before you pop into theatre. For example, you actually need to know a little bit about your patient, or at least have taken a moment to think about the context and circumstances of that patient and that procedure or whatever you're taking consent for. This is really important. I use the example, often of the difference in the way you might take consent between a gogo who lives in a very rural area, who maybe grew up without the opportunity for formal education, and the nervous actuary with a diagnosed anxiety condition, who understands relative risk in a way that is well past your understanding of it. The information you're going to give the two of them for exactly the same procedure must be different, using different words, different level of complexity, different ways of framing what you're talking about. For Gogo versus the actuary is going to want to know all sorts of little details that would just overwhelm Gogo. And so this quote is really helpful. It's from the British courts, but our courts actually do quote British precedent as well, and it's quite thought-provoking. So this judge wrote that a patient may make an unbalanced judgment because he is deprived of adequate information. We kind of know that. But a patient may also make an unbalanced judgment if he is provided with too much information and is made aware of possibilities which he is not capable of assessing because of his lack of medical training, his prejudices, or his personality. One could add his educational background, etc. So this is really important. You can fail in your duty to give the right amount of information by giving too little information, but also by giving too much. And unfortunately, you're the one who has to decide what is too little and too much. Right, I said we're going to speak about the third component, and that is voluntariness. It kind of goes without saying, but again, it's important to just think about the language we use, the cultural differences we might have, the beliefs we have. A very simple example, we used to ask women whether they wanted to hold their stillborn baby. It was for some people, pretty obvious, helpful for grief, widespread around the world, but for other people, it was a complete cultural no-no and not something that you would ever consider doing. And we had some really interesting discussions between doctors and midwives as to how did we give women the opportunity to do that without prejudging her. How did a doctor from a Western culture perhaps present the opportunity without making her feel like she needed to do it to keep the doctor happy? But how did a midwife, perhaps from a deeply rural context herself, present the option which she didn't feel comfortable with and didn't want to do, but in a way that allowed the woman to do it if she wanted to? So divorcing ourselves from our culture and beliefs and presenting what we did in a way that didn't coerce the woman at all. So how we come across, the language we use, the body language we use, all super important in voluntariness. Obviously, mental health patients, mental health care users are at risk of being coerced, perhaps more so than some other groups, and making sure that they also have autonomy is important. And then, of course, there are vulnerable groups like detainees or immigrants who may be at special risk. And, for example, discussing the patient's condition or taking their consent with a member of the correctional services or a police officer in the room is a no-no. So you need to think about whether you've created the right environment for your patient. Documentation, as with everything we do in healthcare, is super important. Keeping records of what one says and does is really important, but can be overwhelming in the moment. So the guidance is to take written consent where there is complex treatment that's being discussed, where there's a significant risk of something going wrong or side effects of the treatment, and that they are consequential for the patient's work or social or personal life. On the right, it has the heading there, implied versus express consent. If you think about taking blood, there are many jurisdictions where actually you need to sign written consent, and if you go and have blood taken at a laboratory, you might actually sign a form, but in our average casualty in the public sector, we don't have time for that, and so we assume implied consent by the patient stretching their arm out to us, and we continue with the procedure. But actually you need consent to take blood. In the early days of HIV, when we wanted lay healthcare workers to do finger prick HIV tests, there needed to be an updated gazette issued by the minister to allow it, because again, we are pricking somebody with a needle that's impinging on their bodily integrity. So even taking blood is an issue that requires consent. We don't usually document it. Of course, we get into grey areas once you've got the aggressive drunk patient with a head injury and you're holding him down. Again, there it's probably emergency consent. You're the one giving it, but it's you can see how quickly it gets grey. Documenting it for surgery, for anesthetic purposes, is more important because obviously the risks go up. And then obviously when the primary goal is not clinical, so anyone who's giving consent for participation in research, that needs to be very carefully documented, because it's not necessarily in the patient's best interests. They're doing it as part of a contribution to society. When consent is refused or withdrawn, that needs to be carefully documented. We're usually pretty good about documenting RHT, but even there, one needs to think about the other information that you're documenting with it and whether it's being witnessed. And again, the process is as important as the outcome. So it's not that they agreed with you. It's not that we got to the right answer or a signature on a piece of paper, but that things were done properly. And that's just important to bear in mind. HIV testing, there's guidelines around when other people are at risk, needle sticks especially, a partner who hasn't been disclosed to. All of those can provide some quite interesting ethical dilemmas. There's the issue of testing without a patient's consent, especially in a needle stick scenario. You need to know what you're doing and how to do it in a way that complies with the law. Public health issues. We've lived through COVID, so I don't need to say too much on that. And end-of-life care, what exactly a valid do not resuscitate order is, what it needs to have taken into account, etc. One's usual practice is valid if it's written down somewhere and can be referred to, but it does need to make reference to something objective that you could, in the last resort, put before a court of law. And information leaflets are important to highlight because they provide the patient with perhaps more information than you have time for in the consult, but a point of reference for them to go back to and remember what you've said, and can be very useful, again, preferably documented that you provided it. And then lastly, of course, if you're not sure, ask. There is a endless number of shades of grey when it comes to the complexity of some of these things, and working one's way through them in situations which you've never encountered before can be very overwhelming, and it's better to ask and know than just to guess. So 4 takeaways. The reminder that consent is a contract to break the law. Making sure that you know what the rules are and when they apply. Respecting the person. We've got to make sure the humanity is in our healthcare. We use the phrase in Njengo Sisiwam, how would you approach this situation if it was your sister, or your mother, or your father? And then appropriate documentation, because we are very much in the era that if you didn't write it down, you didn't do it. Thanks very much. Oh, sorry, I wanted to throw in this one case report. I nearly forgot I'd added it in. This was an interesting one, very applicable to anesthetics. So a case which I reviewed where the woman appears to have needed a Caesar because of a failed induction, and at Caesar she was found to have multiple large fibroids, and for some reason the surgeon felt that they should do a TL, presumably to prevent pregnancy while the issue of the fibroids was being addressed. Now, that's medically questionable, and the age of the patient was also, I think, 21. She had one other child. So this child was actually known to have a congenital abnormality as well. So already a lot of questions about whether a BTL should have even been in the discussion. But the point of this one is that she went into theatre having given consent for a Caesar, and then the BTL was added in another handwriting. Now, sometimes you might have had long discussions and documented it antenatally, and just in the moment of writing down the consent, one forgot to add the BTL. Now, if it's properly witnessed and your patient is in complete control of their mind, you might risk adding that in theatre. But in this case, it appears to have been added post-theatre by the staff, and when I looked at the anesthetic, it turns out she had a general anesthetic, so there was no way it could have been discussed with her mid-procedure, and there goes the case. So one has to really be alert, and the question is the anaesthetist part of that process? Obviously, the anaesthetist should be aware of what's going on in theatre, and I think to some extent we all have a responsibility to be standing up for our patient, perhaps all the more so if you've put them under general anaesthetic. Just some food for thought. And perhaps the last thought then is that the medico-legal realities that I think have many people cowering in fear, almost practicing defensive medicine and running scared even at the thought that consent could be so complex, shouldn't cause us to be fearful, but rather provide an opportunity for us to explore ways of providing better care. That's the end of this presentation. I hope it's been helpful. Reach out to colleagues with experience, medical legal advisors in your area, and think about some of what I've spoken about. There's a lot more to read on all of this. As I said, Medical Protection Society have good material. The HPCSA has clear guidelines on much of it, and there's always more to learn. So I hope this has been a taster that has been helpful, and good luck.